Hello and welcome to the first CIS health testing webinar, all about testing for infectious disease. As said, this is the first in a little series of webinars where we're going to discuss the testing options that are available through the CIS health testing scheme. So we're going to have a little look at what tests are available and what we might use when over the next few weeks. To introduce myself before we get started, my name's Dan Humphreys. I'm a dairy vet by trade, but some of my dairy vetting involves working with CIS to plan some of these health testing schemes and to work out how best to use them, as well as providing a little bit of supplementary advice in particular cases that are needed. So without further ado, the first of these webinars is actually a bit more of an introduction to the topic, and there are some general concepts that it's well worth considering for every disease, really, before that are not specific to one disease, but will help us when we come into talking about the options available for individual diseases over the next few weeks. So the first question is quite an obvious one, really, but is all disease testing the same? And clearly the answer is no. So we sometimes have to ask ourselves, what do we need to provide effective disease surveillance looking for disease? And it relies on three different things, really. One, we have to choose the right test and testing protocol for the situation. There are different tests out there, and depending on what we're trying to find, and depending on how likely it is that we're going to find it, that influences which tests we use. The second one is, once we've got those test results, it's necessary to understand what they mean and correctly interpret them. Different test results are reported in different ways because different tests work in different ways. And so we've got to be aware of what these test results mean and what they mean for the cow and what they mean for your herd status. And then thirdly, it's always really important to understand the test limitations that we have. None of these tests are perfect, and they will be better and worse in different situations. But it's on us to understand what the results might be telling us or what they might not be telling us. And so that is a consideration. Going on to the common tests for infectious disease then. There are a lot of different diseases out there that we could be looking for, and each of those diseases has a specific mechanism of action. And so because there's all these different diseases and mechanisms, there's lots of different tests available. But most of those tests can sort of be categorized into two main methods of detection. We can either look for an immune response to a particular pathogen, so predominantly that's antibodies, but we're looking for how the body has responded to the presence of a bacteria or a virus or other. Or the other option is we can look for the pathogen itself. We can look for that bacteria, we can look for that virus. And so the common tests we use regularly for this are we use ELISAs, and we use PCRs, and we use cultures. There's lots of other testing mechanisms that are available, but those are the three that we predominantly use. And so we'll go through those quickly now. ELISA testing. Right. The enzyme-linked immunosorbent assay. You don't actually have to remember that, but it's so how ELISA tests work is they work by causing a reaction if there's a target protein present. So if there is something we are looking for, that target protein, what we get is we get some sort of chemical reaction that we can pick up, either a color change or light or something like that. What do I mean by target proteins? So target proteins can be a wide variety of things, what we can be looking for. So we can use ELISAs looking for antibodies. Antibodies we'll talk about in a moment, but they are produced as part of an immune response to something. We can actually look for target proteins that are antigens, and antigens are surface proteins that are on bacteria and viruses, and they will, if we find those antigens, shows that there's the bacteria or the virus is present. But they're not always, these ELISA tests aren't just limited to infectious disease monitoring. They can also be used to detect other proteins, such as PAG, pregnancy-associated glycoprotein, as you'll have heard about in previous webinars about pregnancy testing using milk. And so there are a wide variety of things we can look for. ELISA tests are quite good as well because they can give a good estimate of the amount of that target protein that's there. So if there's a lot more virus, there we can sort of count that. If there's a lot more antibodies, sort of measure that. So we get a bit of a quantitative approach. When we're talking about antibodies, it's useful to be clear what we're talking about. So antibodies are an important component of our immune defenses. They aren't the entirety of our immune defenses, but they are an important component. And they are produced after exposure to an infectious agent, really. So that infectious agent, it could be a wild disease, or it could have been the vaccine for that disease. And so what you get when you stimulate antibody production is you get an initial rise in antibody levels, and then those antibody levels will wane over time when exposure stops. These antibodies are largely specific to a particular disease, so they're produced once you're exposed to that disease. And if disease exposure stops, those antibody levels will gradually disappear from circulation. It's important that antibodies do disappear from circulation if they're not used. And we've obviously heard a lot about antibody levels and coronavirus in humans recently, but antibodies levels are only one measure of our immune function. And if antibodies continued to circulate all the time after we'd been exposed to a disease, most of our bloodstream would just be full of antibodies. So it's useful that if the exposure stops, they're downregulated over time. And that time scale differs for different diseases and different amounts of exposure. So the next kind of testing category, and again, we'll have heard a lot more about this in the last few months with coronavirus, is the PCR tests. The PCR tests stands for polymerase chain reaction. And what we're looking for with a PCR test is we're looking for kind of target fragments of the genetic code from the bacteria or a virus, particularly. So that DNA and RNA, which is like the instructions and the genetic coding for what that virus or bacteria wants to do, we can look for those target fragments. And these tests are newer on the scene when compared to ELISAs. They require quite a lot of work, so they are actually quite expensive, but they can be very, very sensitive in particular settings. Some of those PCR tests will also quantify the amount of that genetic code that's present. So it will give us an indicator of how much of the bacteria is there or how much of the virus is there, and that can be useful. We've obviously, like I say, we've seen quite a bit of these PCR tests in the news, and I'm sure quite a few of you will have experienced now the old swab down the throat in the car park that lots and lots of people have had to go through recently. And that is a PCR test and is sent off to a lab to run. They're very, very useful tests, and they've now been adapted into different ways for different things as well. So there's quite a range of PCR tests available, but they are a very useful thing. The last kind of category that we're talking about today really is kind of the culture of infectious agents, and that is actively trying to grow the bacteria or the virus to see if it's present. So what we do is we provide the ideal environment for those bacterial target viruses and leave it the required amount of time, and we see if it's there. So cultures are usually used as like a specialist growth media. You provide the exact environment you want to actually grow the bug you're looking for. You provide it its ideal environment. And they're very commonly used in kind of milk mastitis samples. And then with cultures, we can also expose those cultures to antibiotics or different antibiotics, as in the picture below. We can see which disc of antibiotic has repelled the bacteria or has killed the bacteria off, and how big that circle around it is. So we don't actually do a huge amount of culturing with at CIS, but it is something that is available, and it's something that we commonly have to build, and it just gets done. And again, because you don't have any additional collections, it's cheaper than, say, getting a vet out to bleed a lot of animals. Obviously, for milk samples, you need animals in milk. So that is a limiting factor. So there will always be a role for blood testing. But milk samples, we can use them in different ways as well. We can look at individual samples. We can look at pooled samples, so collections of cows, or we can look at bulk tank samples. And we might want to use those different choices in different situations. So yonis, for example, we very much would look at an individual sample, because bulk samples for yonis are useless. However, looking at an appropriate sized bulk tank sample for BVD virus is a great way of screening all the cows that are contributing to the tank at the time. So that's something that we can always consider. Again, trying to tie in the sampling stuff with a management practice is a really good way of making a job happen, making it easy. So for something to happen consistently, it usually has to be quite simple. So tissue testing is now increasing in popularity, especially for diseases like BVD. And often that's combined with when you're tagging the animal as a newborn calf. So you're doing that management practice anyway, but these tags take a little notch of the ear tissue sample. We can actually store that sample at room temperature for about 3 weeks before we actually need to send it off. So it's quite convenient in that sense. And then once you've got your collection of tissue samples, you send them off to the lab and they can be analysed for some particular diseases. So again, increasing in popularity, very easy to do, very easy to handle and send. And finally, we can also test feces. We don't actually do any fecal sampling at CIS, but for some diseases, fecal sampling is useful. We can either do cultures for things like Salmonella occasionally, or we can do things like PCR tests looking for Johne's disease. It's not something we do at the labs at CIS because we're very much focused on the top three there: milk, blood, and tissue. So we're nearing the finish, but before we do finish, it's important to talk about some of the test limitations. As I referred to in that first slide, sadly, none of our tests that we use for disease are perfect. And we're often also trying to balance a gold standard test versus what's a cost-effective test as well. So sometimes we don't use what is actually the best test on purpose because it might be prohibitively expensive. And some of these test limitations are understood or discussed as the sensitivity of a test and the specificity of a test. So what is the sensitivity? The sensitivity of a test is the ability of that test to detect true positive animals. So an example of that would be if we have 100 infected cows and the test picks up 80 cows, that sensitivity would be 80%. The other side of that argument is the specificity. And the specificity is a measure of how specific that test is to that disease. So are there any other conditions that would also give you a positive on that test or not? And a highly specific test will be very specific to a disease. So it is actually the ability to detect true negatives. So we're not getting false positives. An example of that is that a test can be very specific, but it can also be at the same time not very sensitive. And in this case, what we're getting is we might miss some infected animals, but when we do get a positive, it's unlikely to be wrong. It's unlikely to be a false positive. Perhaps the best example of this one is actually, say, the Johne's testing, where Johne's tests are very specific. If we get positive results, it's very much unlikely to be due to something else. But Johne's testing isn't particularly sensitive because of the nature of the disease. And so when we're doing the milk testing, we might only have a sensitivity of 80%. So we only pick up 80% of infected animals. And when we're using blood products, that sensitivity actually drops a bit further to somewhere about 60 to 65%. So these things are well worth considering. And in that instance with the Johne's disease, in that example, just because it's had one Johne's negative result, there is a chance we might have missed a positive with them. So that's why we do repeated testing, to try and change those odds in our favour. But we will talk a bit more about those individual disease implications and test implications as we go through this little webinar series. So before we finish, what's next? What are we looking forward to over the next few weeks? So as discussed at the beginning, over the next few weeks, we're going to be taking these diseases on an individual basis, and we're going to have a little look at the health testing options that are available to you through CIS, the different test choices, but also a little bit about what the results mean and how we might best use those tests to give us the most reliable data that we can actually use to manage herd health. And if you've got any kind of questions about any of this in the meantime, The contact details are here, so get in touch with your CIS area manager, and there's an interactive map on the website which can tell you who that is if you're unsure. The phone number for head office is just here, and then of course you can email, and it wouldn't be the modern day without some social media options. So CIS are also on Twitter and LinkedIn. So if you've got any questions, feel free to get in touch, but I'll be seeing you over the next few weeks, and thanks very much for listening.